the edge of compassion, sustaining well-being in high stress and trauma-exposed environments. Next slide, please. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. Next. The Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. We encourage you to stay connected by visiting our website at echopalliative.com. And the Palliative Care ECHO Project is supported by a financial contribution from Health Canada. Therefore, the views expressed in the session today do not necessarily represent the views of Health Canada. Next, please. Thank you. Many of you might know Pallium Canada for our LEAP content, our LEAP courses. Predominantly, one of our most popular courses, our LEAP Core, which is an interprofessional course that focuses on the essential competencies to provide a palliative care approach, can be delivered online or in person, and is accredited by the CFPC and the Royal College. If you'd like to learn more about the course and topics covered, you may visit our website. We have added a little link in the chat for your access. Next, please. So I'll introduce myself. My name is Diana Vince. I'm the Palliative Care ECHO Project Manager at Pallium Canada. I'll just briefly hand it over to our presenter to allow her to introduce herself.
Good morning, good afternoon. My name is Francoise Mathieu, and I am a registered psychotherapist and the Executive Director of Tend Academy based in Kingston, Ontario.
Welcome so much, Francoise. We're so happy to have you back. Next, please. I'll go in through the welcome and reminders. So for comments and introductions, I do see that the chat is moving along. So thank you so much for introducing yourself. Please be mindful that if you do have a question, we ask that you use the Q&A function. If you hover at the bottom of your screen, you will see Q&A. Please pop it open and insert your question there. And at the end of the session, we will address all of the populated questions. The session is being recorded. This recording and slide deck will be emailed to registrants within the next week. And please remember not to disclose any personal health information during the session. Next. Briefly, the conflict of interest. So Pallium Canada is a non-for-profit, partially funded through a contribution by Health Canada, and we also generate funds to support operations and research and development from course registration fees, along with the sale of our pocketbook. I myself, along with our presenter, do not have anything to disclose, as you see in front of you. And without further ado, I will now pass it along to our presenter.
Thank you so much, Diana. I could listen to your very soothing voice all day when we talk about managing stress and high stress pressure situations. I find your voice very soothing. It was a lovely way to start. Hi, everyone. It's really wonderful when I'm looking in the chat to see that we are really from sea to sea, from coast to coast. There are folks from all over Canada. Oh, we even have some folks from the US. So really pleased to be with you today. This is my 4th ECHO Cares presentation, my 3rd in Canada. It might actually even be more than that, but I've done at least 3 ECHO Cares presentation in Canada, several in the United States. And what I wanted to focus on today is the way I was thinking about it is that it's not the introductory level presentation on secondary traumatic stress or empathic strain. It's really an exploration of how do we sustain ourselves when we work in these really challenging, very rewarding, but very challenging work settings. I'm not going to spend too much time on my background because we don't have a lot of time. I find that this hour goes by very quickly, and I want to have a chance to have some Q&A as well. But my very quick kind of background is, as I said, I am coming to you from Kingston in Ontario, traditional territory of the Anishinaabe, Haudenosaunee, and Huron-Wendat. I'm originally from Quebec. You can probably tell based on my accent and my very French Canadian name. I spent the first decade of my life in the high Arctic. My parents were teachers in northern Quebec, and I lived in mostly Puvarnituk and Kutuak, and had direct kind of experience of the challenges, the beauty, and also the challenges and inequities of multi-generational trauma and gaps in terms of healthcare resources and community resources in the North, as we know well. I became interested in trauma and crisis intervention and became a mental health professional in that field. Many years later, I became a hospice volunteer, and I had the incredible privilege and pleasure of working alongside palliative care professionals. And what I'm going to talk about today also is informed by that experience. So I've been in the field for over 25 years now, and mostly working in healthcare, but also law enforcement, military, what we would call high pressure, high stress environments. And I remember that my very first volunteer job was in a hospital emergency ward. I lived in the UK at the time. And then when I moved to Kingston, I started volunteering at the Kingston Penitentiary, which many of you know is now closed, but was the oldest maximum security prison, one of the oldest ones in continuous use in North America, but the oldest in Canada. And I was volunteering with Indigenous men who were serving life sentences. I'm going to go back to those stories in a minute. My daughter, who's 26, just celebrated her birthday yesterday. Her partner is a nurse in one of our maximum security prisons here in Kingston. And you can imagine that a lot of the work he does at the hospital in the prison is palliative care. People who are serving very long sentences who are towards the end of their lives, and that's the support he provides them. Throughout all of those experiences, I've had lots of conversations without, of course, ever breaching confidentiality, but I've had many conversations with him as a nurse who does palliative care, in my own experiences as a hospice volunteer, but also with all the different professionals that I work with every day. And the question is always, what is the sweet spot? What is the sweet spot between not caring at all and caring too much? And I think you will agree with me that there are some patients and some families that are simply easier to like than others. I'm just being really candid here, right? There are some individuals and families, sometimes it's more their families, that are particularly challenging in terms of us feeling that empathic or compassionate engagement. And there are other situations where I certainly started seeing this in the prison system and in the ER, where we find that some professionals have really seemed to have lost their ability to be present. And there are a whole bunch of reasons for that, which is beyond the scope of my conversation today. It's something that is often referred to as compassion fatigue or empathic strain. Sometimes it's got to do with very similar cases, right? So I'm sure you've all had situations where you've seen umpteenth number of individuals who all kind of fit the same profile. They're the same age, they have the same diagnosis, they might even have the same name. And there are other situations where we find that their stories really hitch a ride with us. And my question, and it's something I've been exploring extensively for the last 2.5 decades, is what is a sweet spot? How do we find a place where we can care just the right amount for people who are often at, the end of their lives or facing life-limiting illnesses? So I actually gave a TEDx talk about this in 2017. If you have family and friends who have not a lot of time or a short attention span, perhaps you can invite them to watch it. It's only 60 minutes, and it's a very brief overview of kind of the area of work that I've been doing, looking at compassion fatigue, empathic strain, secondary traumatic stress, but also exploring this notion of that sweet spot. What I wanted to talk about today actually comes from a recent chapter that I've published. That is not the chapter that I published. I recently published a chapter in a book that will feel not related to your work at all. I do a lot of work in the child abuse and family maltreatment field. And this chapter was really an invitation by the editors for me to do a full comprehensive review of the research as we are today. And I find that really important in terms of staying current. And this chapter basically allowed me to review all the literature as of today, 2023. Where are we at? What are the findings? What are the best practice recommendations? And that's what I really want to offer you today. So going back in time, a lovely colleague of mine, Richard Harrison, who was at UBC at the time when we met, wrote just a gorgeous paper in 2009. His PhD thesis was also inspired by this. And what he wanted to know is, what are these practices? Let me back up. What he wanted to know is, why are some practitioners in our field able to stay well for very long periods of time? And why are some people unable to stay and sometimes decide wisely to leave the field or to switch into another type of specialization? And what he did, this was a qualitative study where he interviewed peer nominated clinicians. So these were folks that had been identified by all of their peers as beloved mentors, trusted clinicians, people who really, that you would think of. And I want to invite you to think of people like that in your life right now that you really look up to as having a very positive influence on the work. Now, it's really important to make it clear that these people don't necessarily have a seamless path. I don't think any of you, I don't know how long you've been in the field, but I don't think any of us have these perfect, kind of beautiful, Miss America moment every single day that we're in this field for 30 to 40 years. We will, of course, have ups and downs. We may even experience burnout. But what was really interesting about these individuals is they all identified the same protective practices. I'll highlight a couple here in the interest of time, but you're welcome to go and read this beautifully written paper by Richard Harrison and Marv Westwood. And what they really found is that these folks had very similar practices that allowed them to stay well and present and compassionate in spite of all the many challenges that healthcare experiences. Here's the chapter I wrote. So the chapter that just came out, it's called Managing the Things We Can't Unsee. It is published in a book called Child Sexual Abuse, Practical Approaches to Prevention and Intervention. If you're interested in the literature, by the way, I would really invite you to cast a broad lens and not be put off by the notion of looking in a field that probably has nothing to do with what some of you do. And it turns out that the field of child sexual abuse has some of the best and the most in-depth research on provider impairment. And so when there is a gap in the research in your particular field, I really invite you to consider looking in that literature. So particularly looking at research on secondary traumatic stress in the child sexual abuse world, that's where I would go. So that's why I wanted to mention this book chapter. So what I really became interested in, so let's back up a little bit. At this point, I'm volunteering at this prison. I have just finished volunteering in this hospital emergency ward. And in both instances, I met some professionals who were, some of them, completely crispy fried. I'm sure you know what I mean by that. These are individuals, perhaps you've worked with them, who have a retirement app that says, 18 years, 2 months, 1 day until I retire. They're not close to retirement. They are truly doing time. Individuals who seem to have lost, or maybe never had, the ability to have compassion towards the more challenging patients or clients that they work with. And hopefully you haven't seen that a lot, but I certainly have, unfortunately. And what became really interesting in both of those interactions or situations is that this did not necessarily correlate with years of service. And what's really interesting about that is we would intuitively perhaps think that it would be directly linear, so that you'd think that the person with 20 years of service in healthcare would be more burnt out than someone with 3. That's not at all what the research shows. In fact, there's some really interesting data that came out a little bit before the pandemic by the Canadian Medical Association that found that residents had some of the highest rates of burnout and emotional detachment. So they were looking at people who had been in the field for about 3 to 7 years. In nursing, and you can imagine that was amplified by the pandemic, we start seeing higher rates of burnout around 3 years of service, not 15 years of service. And so that became really interesting to me. Of course, we know that some healthcare professionals select themselves out. So there's natural attrition, right? I'm sure you've all had colleagues who at some point said, this is not the right fit, and they're going to go and do something else. So there's a natural drop off. But what became really interesting is interviewing people who had been in these professions for a long period of time and finding out what had they done that allowed them to stay well. Those are called career sustaining behaviors. And I'll go back to that in a minute. So As you probably know, particularly in medicine, medicine is known for some pretty great titles of abstracts and papers. And this is definitely another two examples of that. So there's a study here by Margolis and Malinsky, and then another one by Ashford and others. And there are two studies I want to talk about very briefly. So the first one is about, you'll see the title there. It's called Navigating the Bind of Necessary Evils. I'm going to go back to what necessary evils are in our field. And the other one is Ashworth does a lot of work on what are called dirty jobs. I'm not in any way suggesting, by the way, that jobs are dirty. I want to explain that. These are jobs that have a public perception as being tainted in some way. And what both of these studies wanted to do is find out, how do people in those fields cope with that kind of perception, and how do they stay well in spite of those challenges? So the first one is necessary evils. Necessary evils are tasks in which we must knowingly and intentionally cause some type of distress or physical harm to another individual in the service of achieving a greater purpose. A really good example of that would be performing a lumbar puncture that is life-saving, right? So my daughter, a couple of years ago, she's fine, but they thought she might have meningitis, and she had to have a lumbar puncture. So that's a pretty good example of needing to inflict necessary pain on a patient. We're not going to go into debates right now about procedures that we agree or disagree with. That's not what I'm talking about here. But these would be really good examples where they, for example, you might be working in oncology, in pediatric oncology, and say, this is necessary in order to save your life. Lots of other examples of jobs that involve necessary evils, layoffs, death notification, duty to report, in terms of child welfare, child protection, reporting another professional, having to report a nurse who's made a medical error, a physician who's, whose practice is reportable. I think you understand. So those are called necessary evils. Dirty jobs are occupations that have societal taint. And I want to invite you to think about, and you can use the chat here for this. I want to invite you to think about whether, particularly if you work in palliative care or hospice, have you ever had a citizen, like just the general public, have a reaction to you telling them what you do for a living? So I'm just going to check the chat as I keep going here, but have you ever been to, and I'm referring to civilians, like people who don't work in this field at all. Have you ever been to a holiday party where you tell them what you do and people had a reaction, right? So examples, and go ahead in the chat if I want to check whether you've had that. I have lots of examples of that. People saying to me that I either have a reaction of instant, mixed reactions, right? Someone saying that instant sainthood, like, oh, bless you for the work that you do. Or can I tell you all the different, gory details of what's happening? Or all the way from you are doing God's work, you're a saint, to can you tell me, is this a rash that I should be concerned about, to I really don't want to talk about it because death and end of life makes me deeply uncomfortable, right? And so those are basically and someone just put in the chat as well, these whole conversation around MAID in Canada, which of course amplifies the conversation. So I think we can all agree that you and I work in jobs that have some type of social taint in certain fields, right? So thank you for sharing that. In their study, they had lots of different folks here. So whether it was pest control, corrections, probation, collection agents, debt collection, ER nurses, I'm not sure what ER nurses did to these folks, but funeral directors is a really big one too. People who work in hospice, internal affairs, so police officers who have to investigate other police officers, all social workers for some reason, and personal injury lawyers. So what they wanted to know in this study is, what do we do, us, since we're here in some way, what do we do to stay well in spite of this occupational taint and necessary evils, where sometimes we have to inflict some type of emotional or physical pain in pursuit of the well-being of the individual. So what they found, there were lots of things. They're great studies. I recommend you take a look at them. But what they found is that a lot of us engage in coping strategies, such as reframing, right? Someone's got to do it, so it might as well be me. And I certainly remember when I was working with, I went a couple of days to St. Jude's Hospital in Memphis. some of you know well, it's one of the best pediatric cancer care clinic hospital in the US. And what these folks said to me is they said, look, I'm really good at X, Y, and Z procedure. So if someone's going to do it, it might as well be me because I will do it well, right? I will do it with kindness, compassion, skill. So that's a really helpful way to reframe it. Social buffers. So that's perhaps going to a conference or convention or only spending time with people who also do similar work so that we don't have to explain ourselves, correct? Like we just can relax and just be ourselves and don't have to get into all the details. Dark humor. I know that I certainly try to avoid dark humor. It can sometimes be problematic in terms of, talking disrespectfully about individuals, sometimes kind of grim humor. But I think we can agree if any of you know anyone who's a funeral director, they have some of the, pretty interesting sense of humor. And sometimes it's just a way to relieve tension, and providing that we're not doing it in a way that's disrespectful or violating confidentiality. I think that there's a place for that in a very small way. I tend to try to avoid it, but we know that happens quite a bit. Some of you have actually already shared in the chat that you do the fourth one, which is avoiding, which is that you basically tell people what you don't tell people what you do for a living, right? Or you just say, oh, I'm a nurse, but you don't say what kind of nurse. And so I've heard that from thousands of professionals. I was just in New Jersey last week working with the New Jersey judiciary. So this is all the judges in New Jersey. And many of them told me that they actually lie and they don't tell people that they are judges when they go out in public. Another one that's interesting, and I want to invite you to see whether you've done that in your field, is social comparison. I see this a lot with law enforcement, for example, where law enforcement will say, there's a hierarchy, like we're better than paramedics or what have you. I see this in the trades. As I'm sure you know, if you know anyone in construction, there's a hierarchy, right? Roofers are not considered to be on par with electricians or plumbers. And yet we're all kind of working towards the same goal. But I think we see this in our professions as well, right? What is this hierarchical kind of social comparison? We see this with allied health not always being included in the same way in certain environments. And that's a very familiar coping strategy. The final one, which is to me connected to compassion fatigue or empathic strain, is distancing. And so sometimes, and I'm sure maybe you've never done it, but I'm sure you've seen it done, where we go into this blaming role, right? So we might still be very attached or connected with our patients, but we might blame their families, or we might create this emotional distance. Sometimes also we'll create a distance in a way of thinking about, well, this issue couldn't not happen to me because I didn't do the following things that I consider to be problematic in terms of the way that the patient took care of their health or what have you. These are normal. We just need to recognize them to see that what we're doing is we're really coping with these complicated jobs that we do by ways of creating all of these kind of emotional and behavioral kind of strategies, if that makes sense. So what are career sustaining behaviors? So out of all of that, who are the individuals that we have found who stay well for long periods of time? And what's the difference between them and those who do not? So basically, simply put, why do some people thrive in this work and others don't? And I bet that some of you absolutely love working in palliative care, right? That you feel like this was your calling. And there's some of you where, let's be honest, it's just a job, and that is okay, right? It's okay to say, this is just a job, but it doesn't feel like it's the right fit for me. So here's what the research has found. So after a few years, as I said earlier, some professionals make the wise decision to move on into a different line of work or just different specialization. And let's be honest, we are all extremely relieved for them to go because they're just not in the right place. Unfortunately, what we know and what we see is that others, they choose to stay, but we see real functional impairment. Functional impairment simply means that their functioning is impaired physically, psychologically, socially, emotionally. And we also see a shift in their ability to demonstrate and experience empathy towards their patients and colleagues. And you all know individuals who are like that. And yet there's this third group. And for this third group, these individuals seem to be able to continue working in the field for decades without developing debilitating impairment while retaining an overall sense of job satisfaction and well-being. And why is that? And again, I want to make it clear, none of these people are having a perfect day every day. None of these people are pretending that the social system isn't completely compromised and that we don't have huge wait lists. Like, that's not what's going on here. There's something in them where they've been able to develop that sense of job satisfaction. And I wanted to understand a little bit more why that was. So career sustaining behaviors found that these third group, they engaged in these behaviors. And there's someone in the chat right now that made such a good point that said, I love being a hospice nurse. It's where I'm meant to be. However, I am exhausted. And those two things can actually coexist. If you've been to my previous talks and if you've seen my Venn diagram where I explore the difference between burnout, empathic strain, secondary traumatic stress, those things can absolutely coexist. So what we found is basically, as I said, none of them had a perfectly smooth professional journey, but they said that their work experience was deeply rewarding and soul sustaining. So the one thing we have found, what matters the most is who you work with. Your workload matters too, of course. But what we found is that mutual support and who you immediately report to matters more than where you work. So I want to invite you to think about that right now. If some of you work for a large system, I had a colleague who worked at Hamilton Health Sciences, 15,000 staff. What mattered wasn't who was the CEO of Hamilton Health Sciences. What really mattered were her peers. Did she have access to timely and safe debriefing? Did she have a chance to feel, again, safety, comfortable talking about emotional challenges, clinical mistakes, that sense of safety, but also having someone that you report to that you actually trust and that has enough experience to be supportive to you. One of the key career sustaining behaviors is a feeling of mastery. And mastery is feeling confident and competent. I invite you to think back, those of you who've been around for a while, what was it like your first year on the job? Did you feel confident and competent? And I hope that you didn't, right? Because I don't know about you. I don't want a brand new healthcare professional to feel overly confident because I want them to actually consult and I want them to, make sure that they're not going in to do something that they might not actually have yet developed the confidence and competence to do. So part of what's protective when we've been in the field for a long time is that we know what to do. And I know personally as a crisis worker that the very first suicide assessment I did was understandably extremely stressful. And the 200th one I did was still a little bit stressful because you want to have that adrenaline. But I felt like I knew what I was doing, but I also had access to proper training, proper debriefing. I had access to resources. So I want to invite you to think about that right now in this landscape after 3+ years of the pandemic, when we've had not only the trauma, and this was a talk I gave last winter or last December to Echo Cares, was talking about the frank PTSD and burnout that we're seeing, particularly in long-term care among personal support workers and nurses and other folks who worked in the ICUs, for example. But want to invite you to think about what is it like right now working with staff who are brand new. There's a lot of career mobility, people retiring, and that absolutely diminishes for some time our overall sense of mastery because they're new and how can they know? They don't have a chance to learn. They don't have a chance to learn in the way that we used to learn. So for new staff, people need time to learn and grow on the job. And I'm working with a lot of organizations right now where even people in supervisory roles have barely been in the field for very long. Well, we need to support them so they get to a place where they feel confident and competent. There was a really interesting study. Yes, I'm quoting a study from 1964. It was a study that talked about 3 components of a stressful work environment. I want to invite you to look at this and think about whether that is true for you. Role conflict. So particularly those of you who are in nursing, we started seeing this amplifying in the last decade where you basically had too many hats to wear. So conflicting demands, role ambiguity, lack of clarity about what are the expectations associated with my role, and just frank job overload, right? So those of you who are telling me in the chat that you're absolutely exhausted, that's about job overload, but also lack of clarity or just not enough people doing this job. Okay, so here's some more data that we found recently as part of my book chapter. When we're talking about working conditions, we're talking about a couple of things. One of them, of course, is unreasonable and unmanageable workloads, time pressures, but that's also true for supervisors, right? And we're finding that those of you in leadership role are also finding your workload to be unmanageable. But the other thing that's interesting, and I get a lot of questions about this when I speak to organizations, is also about what we call caseload composition. So caseload composition, let me back up a bit. So I don't know, all of you probably do different kind of work, and I bet not all of you work 12-hour shifts, but I'm just going to use that as an example. It's not a 12-hour shift that's exhausting per se. I mean, yes, it's tiring. What's exhausting is the ratio of different types of cases that we're working through during that day. So I want to invite you to think about, I bet there are certain patients that you care for and that you work with who are actually quite nourishing for you to work with, correct? And there are other individuals for a whole range of reasons that are just more draining. And it might be about the complexity of their health diagnosis or their health concerns, or it might also be their personality or their loved ones, or it might also be the colleagues, the team that you're with. So if you have a really strong team, it can be a really good shift. And if you have all of those complexities, it's going to be far more draining as a shift. All right, so I'm sure you recognize me. This is me in 2015. So in 2015, I've been doing this work. I've been in the field for a long time, but I've been doing this work on secondary trauma and compassion fatigue for 15 years at that point. And I'm starting to be really perplexed about this overemphasis on self-care, stress balls, all the workplace wellness that I'm in no way disrespecting, but I'm sure you've all had these situations where you are receiving, emails about breathing more and how, going to yoga is going to fix all the things. And I start thinking to myself, surely to God, that's not what's really going on, right? So I think we all know how to be well. I don't think any of you need a lecture that drinking Red Bull before bed is going to interfere with your sleep, respectfully, right? And so I actually wrote pretty comprehensive article, which you can find in your handout online. It's free, it's available everywhere. And it's called Beyond Kale and Pedicures. And in this article, I spent time interviewing healthcare workers and other professions, trying to understand what is truly needed for organizational health. Excuse me. What do we need in order to stay well while working in this field? And what we found is that the pandemic really amplified all of the cracks that were already there. But we really found that a lot of staff were feeling increasingly frustrated by being sent well-meaning workplace wellness emails, or by being sent well-meaning, leadership communications such as, please consider, contacting our employee assistance program. And what I'm hearing from so many staff is, I don't need another workplace wellness webinar. I need you to listen. I need to feel heard. I need my workload to be acknowledged. I need flexibility in terms of my ability to do this work. Those are the things that people are truly asking for. So the conclusion of this chapter, this article that I wrote, is that, I personally found, reviewing my own challenges in my job, is that I was far more upset about my working conditions, my unmanageable workload. I was far more upset about those two things and I was also morally distressed about the clients that I was working with. I was morally distressed by having to turn them away. I was morally distressed by hearing the gaps in resources. I was not particularly traumatized by their stories. Yes, their stories had an impact on me, but that was not the bulk of what was going on here. I have spoken elsewhere about my belief that we are using burnout as an umbrella term in the field, and that I think that's a mistake. I think burnout is one component of what's going on. But what we need to look at is there are so many different other elements that are happening here. And I invite you to think about, what are the stressors in terms of are the primary stressors for you right now your workload, or the quality of your team, or the type of leadership you receive, or compensation, or the nature of distressing stories that you hear and see, or the lack of resources, or what's going on in your life? And I suspect that some of you will say all of the above. Fair enough. But what I find really helpful is getting that framework and understanding what is the art of the possible there. What are the elements where I can actually highlight, what are the strengths available for me in terms of my current workspace or somewhere that I'm going after this. So in 2015, based on this paper, a few colleagues and I decided that we need to have a think tank meeting. We need to have a whole conversation about what's going on. This is, we're having another one this year, but this is our first meeting in 2015, and we're all experts in the field of secondary traumatic stress and compassion fatigue. And we meet and we create a paper, we publish a paper of best practice recommendations. And again, all of these resources are free. And what we create after that, so we come together and we continue to meet regularly, is we recently published best practices. And this is, I want to talk a little bit about this tool because it can be a tool for you. If you're listening to this and you're in a leadership role, you're going to see an organizational framework. And if you're listening to this and you're in an individual role, these are the best practice guidelines that I would encourage you to consult after I presented today. So let me tell you a little bit what this is. So first of all, to access these, you simply need to go to the website that's there, stsconsortium.com, and you just click on the button, pull in your information, and you can download them. These were developed as expert consensus guidelines. Expert consensus guidelines are the next best thing when we can't do randomized controlled trials, which there's absolutely no way that we can do that looking at these best practice recommendations. Expert consensus guidelines are conversations that we have. It's a modified Delphi process that I won't go into today, where we talk to all the experts in the field, and we eventually, takes quite a few months, come to an agreement where everyone consulted agrees that these are the top best practices to address your secondary traumatic stress and other work-related stressors as an individual and as an organization. So if you're listening to this and you're thinking, I don't know where to start. I'm an individual worker and I don't know where to start addressing work-related stressors. I invite you to download these practices. As I said, they're absolutely free of charge. And you will see that we have several, I think there are 6, there might be 7, don't quote me on that, key recommendations with resources below each that help you have a very well-informed assessment of what it is that you need. So just a snapshot here. I won't go through them all, but you're going to see, just taking a look here. So there's 7. You're going to see 7 categories, and you're going to be invited to reflect on whether you have the ability at this point, for example, to learn on an ongoing basis about secondary traumatic stress. We'll go through, you'll see at the bottom, accessing external professional supports as needed. How do we self-monitor? But I want to focus on tools for emotional arousal recovery. This is, in my opinion, the absolute best thing that you can focus on. If you, like many people I've spoken to, say to me, listen, Francoise, like, I don't have control over where I work. I have, let's say, there's one hospital in my community and this is where my job is. I don't have control over my team. I don't have control over my hours. What can I control? I really want to invite you to look at what we call tools for emotional arousal recovery. That's a very long phrase to simply say, what are the ways in which we can recalibrate ourselves every single day? How do we get back into our window of tolerance? How do we deal with really simple strategies so that we are fully present day in and day out? And I'm sharing here an exquisite book written by my colleague, Brian Miller, who's also on the think tank. And he's a psychologist and he's an expert in basically looking at very concrete tools to sustain ourselves in the helping profession. I highly recommend this book. It's not a big book. It's not very expensive. I should disclose that I wrote the foreword to the book, but I have no investments or financial conflict. And Brian in the book really questions the benefits of after work recovery method. The after work recovery method, we're all familiar with it. It's basically white knuckle it through our day and then, collapse on our yoga mat. This just last week, I had dinner with my daughter and her friends in Toronto where they live. And 2 of them after dinner, they left dinner early because they said they had to go to a breath work workshop. And I was like, that's amazing. I love breath work. It's so helpful. But they had like quite a copious meal I had cooked for them. And they said that they went to the breath work session and fell asleep and slept during the entire thing, which I thought was quite hilarious and probably what their body needed. So after work recovery method is what we all do. You know, we wait, we're like, can't wait till my vacation. And then we finally go on holidays and then we get sick, right? And the way I say it informally is I honestly like do whatever you want after work. And I'm not saying that I recommend, you know, spending 7 hours on TikTok or Instagram while drinking a bottle of wine. Of course I don't. But what we're really interested in the field right now, what we're really focused on is finding strategies to deal with the challenges of our work in the moment. And that doesn't cost money and it doesn't take time. What we know, and Brian says it better than me, is basically after work recovery method of waiting until work is done is not actually a successful way to process difficult exposure. Two experts in the field of neuroscience talked about this in their respective publications. And basically what they say is when we are dysregulated, which means that we are outside of our window of tolerance, even if we successfully pretend to the world that all is well, we're more likely to lose the ability to be fully present and to think clearly and problem solve. This is what we refer to as being outside of our window of tolerance. And very simply, when you think about it, and I don't know if I put my window, no, I didn't. The window of tolerance, if you're not familiar with it, it's a very simple framework to think about. We all know when we're in our zone, when we're well, correct? I'm sure that you have days where you're well rested, relatively. You feel on, like you're in the zone, right? You're able to focus and concentrate, and you probably know what takes you out of that window into hyper or hypo arousal. For example, I bet some of you get hangry, right? I'm sure you know who you are. Like when you haven't had enough to eat, your window of tolerance narrows and you go into, you know, irritability, or you can't think straight anymore. Other people, we have a narrower window of tolerance when we haven't had physical exercise. For some people, it's when we haven't had time alone. I get very hyper overstimulated when there's too many people around. I'm an introvert. And I can feel it when there's a lot of noise and chaos, you know, in my personal life, that my window of tolerance narrows more and more. This is a beautiful book if you're interested in lots of really concrete skills for parasympathetic recovery. This is the book I'd recommend. And because we're coming up to the holidays, I also wanted to recommend another just beautiful book by Pooja Lakshman, who is an American psychiatrist. And I absolutely love this book. It's called Real Self-Care. If you're looking for something, you know, a book with a pink cover, as my friend said, but it's not a book with a pink cover. That's the thing. Pooja in this book explores kind of that, you know, wellness industrial complex, and she proposes very different types of self-care recommendations. So nothing to do, as she says, crystals, cleanses, and bubble baths not included. Her recommendations for self-care are the following. One of them is setting boundaries and learning to deal with guilt. I wrote a piece on that. You can find it again in the resources I'm sharing with you, called Disappoint Someone Today. I think a lot of us have trouble saying no, setting boundaries, and Lakshmi talks about that as one of the key foundational principles of real self-care. She also talks about, let's see if I have my slide here, developing self-compassion, getting clear on your values, and collective action. If you're struggling with boundary setting, I would recommend Nadra Tawwab's book. She's a social worker in the US. This is a gorgeous book. So I'm giving you resources if you want to kind of explore this further. Kristen Neff's focus on self-compassion is a whole body of work that some of you are very familiar with. And if you're not, what Pooja is basically suggesting is we cannot have compassion for others if we don't first have compassion for ourselves. And in Kristen Neff's website, lots of free resources there again. The way that we offer self-compassion to ourselves is when we notice that inner critic beginning, where you probably are familiar with it, you know, that criticism that happens. And she invites us to label those and to, first of all, say and name it and say, this is a moment of suffering. Suffering is part of being human. May I give myself the kindness and understanding I need as I would give it to other people. The third principle is getting clear on our values. And I saw in the chat that several of you were talking about the moral distress that many of us were experiencing, continue to experience, but as a result of the pandemic. and naming and exploring tools for managing moral distress. The final one is collective action. So as I said, these are not your usual self-care recommendations. Collective action is, are there ways for us to be able to be engaged in advocacy, small or in a big way, at whatever level we can be? And I can tell you right now that, as counterintuitive as it may sound, for me, presenting on compassion fatigue, empathic strain, and secondary trauma truly feels like an act of social justice, because if I can invite judges, police officers, physicians, nurses, allied health workers, social services workers to recognize that the erosion of empathy they're experiencing is potentially harming the individuals in front of them, having a potential negative impact. If I can invite us to recognize that erosion of empathy that we may experience, I honestly think that that can alter the quality of care we provide, even when we don't have control over the bigger system. So I want to make sure we have time for questions. So I want to talk about a couple of other things, and I'll open it up and see if anyone wants to pop anything in the Q&A, please. It's a good time for that. So the way that you can probably tell based on this very informal presentation that I'm a really big believer in evidence-based practices, and when that's not available, evidence-informed. So that's my belief. I think that we need to make sure that we are looking at good quality research when it's available, and how can we develop a very well-informed roadmap for ourselves. So some of the questions I want to leave you with as a reflection is, how much influence do you have on these for yourself and or for your staff if you're a leader? Flexibility. And I know some of you are going to say we have zero flexibility in terms of our shift work. So I'm just going to put it out there. Do you have flexibility? Do you have access to regular support and genuine encouragement? Do you have the ability to be autonomous to some degree? Do you have any control over timelines of any kind? Do you have a sense that you're doing something meaningful? Do you have confidence and competence in your job? Do you have the ability to grow in the job? Those are the elements that have been found to be really protective. So before I turn to some really good comments that are coming up here, I want to invite you to consider, just to start with you, and to take a careful audit of the factors that contribute to increasing your stressors and those that help mitigate the impacts of the work. Identify what your warning signs are. What is your zone of tolerance? And remember that research on emotional arousal recovery shows that there are strategies that trauma-exposed professionals can use in their daily practice to reset and recalibrate. And I want to invite you to take some time to learn what those are for you. Surround yourself with colleagues that you trust and you feel safe being vulnerable with. If you're a supervisor listening to this, I really want to encourage you to reflect on your own functional capacity and on the impact that secondary trauma exposures had on your own well-being, as well as your own strategies to recalibrate when staff turn to you for support and guidance. This is one map. You might have a different one. This is my own. This is basically what I do to try and assess, how I'm doing in terms of day-to-day well-functioning. I kind of check this about once a week. I call it my balance map. It might be different for you. At the very top are the 3 key things that I need to have in place. They're just really basic. Simplifying, what does that mean? Might mean something different for you. I like to not have to worry about, day-to-day things like, where is my snow broom when I have to leave the house? Like, just simple things like that. My basic physical health, understanding my reactivity to change that was really amplified during the pandemic, and so on and so forth. So that's just one example. Before, again, I turn to questions, I wanted to mention a couple of free resources. So you may know already, but my company has been hosting a free compassion fatigue. It's been changed now to Care for You, a free conference for many years, and it's now virtual. It's called Care for You. It is offered every June. And if you sign up, you get access to the recordings for a week. And last year we had 5,000 participants. It is absolutely free of charge, folks. So that's why I feel comfortable mentioning it to you. And it is a conference specifically exploring all the things that I kind of very briefly talked about today. So if you're interested, please tell your colleagues and your friends, and it's available anywhere. As I said, people just register and they get access to the entire day for free, and then it's recording. Okay, so I'm actually going to move over to the Q&A here, and I'm seeing some really great comments. So someone's, thank you for additional resources. You're welcome. I sometimes am told I share too many resources, so I appreciate that. Here's a question. Are there any unique or groundbreaking institutional practices that you've seen that have helped significantly with addressing compassion fatigue and or vicarious trauma? Yes, absolutely. Groundbreaking, I'm not sure. I think that, but successful and effective. Absolutely. We know that in terms of the research, what's been very helpful is mindful self-compassion practices. So that's Kristen Neff's work. I'll talk about group strategies in a minute. Trauma-focused CBT, so trauma-focused cognitive behavioral therapy, has been found to be really helpful in addressing secondary traumatic stress or vicarious trauma. In terms of workplace practices, I'm not going to lie to you, there is no workplace currently that is getting 100%, A+ rating on how they're coping, because it is such a fractured landscape. So I'm not going to pretend that that's the case. But what we're seeing right now is that we're seeing a lot of really helpful practices that are happening in terms of proper, timely training, proper and timely team building, timely debriefing, and we have a whole program that is showing people what is true debriefing. How do we develop mutual support? Building competencies among leaders. Sometimes we spend so much time supporting our frontline staff that we forget that, people say to me, should this be top down, bottom up? And I say all of the above, but I spend a lot of time encouraging senior leaders to support managers and supervisors so that if we have limited dollars, build capacity there, and that will ripple down as well. I'm seeing some comments here also, people talking about bringing therapy pet into the hospital team. Yes, I'm a huge fan of that. This is a really good question too. When the culture and setting is not one of compassion and care, it's difficult to sustain and champion this in a team. I agree completely. And this is where it's too easy, right, for us to say, oh, well, if you don't work in a team where you're satisfied or happy, you should go somewhere else, because sometimes that's not an option for us. But the team and the culture influences everything. So if you are in a situation where you don't have a good workplace culture right now, but you, for whatever reason, are staying, I really want to invite you to consider who are those really quiet champions in your workplace. The crispy fried, really, disenfranchised, disconnected, burnt out people are often the loudest. And I remember working somewhere where those people, first of all, I had to use compassion to think about them. And I would think that individual who is being cynical and negative, she is suffering. Like truly, that person is suffering. So that helped me, right? Also kind of have this perspective and not just think this person is a insert insult here. But I also started thinking about, how do I divert the river around her in a way that I can actually create a community of other colleagues who are also interested in bringing compassionate care to our workplace. And that's what I started to do. That's all the questions I see at this point. Seeing lots of good comments. Oh, yeah, one more here. Oh, one more, Diana. In addition to CBT, what additional trauma-focused modalities have you found helpful or heard positive results about? So a colleague of mine who's a psychologist did a whole review of this, and they also found that EMDR has been found to be really helpful for people who have significant secondary trauma exposure, eye movement desensitization reprocessing. So EMDR is a really big one. Some people have found neurofeedback to be really helpful. To be honest, here's the most important part. Going to see a practitioner who is familiar with the realities of the work that you do and who understand and recognize secondary traumatic stress, but also modalities that have been found to be helpful for PTSD are helpful for STS as well. I'm going to take one more, Diana, because one more just came in. Someone said, in Ontario, we're advocating for primary care to be delivered by teams of professionals working together. I wonder what recommendations and references you have in order to get these teams right. Alia says she's going to answer this question, so I'll turn it over to you. Okay, over to you, Diana.
Thank you so much, Francoise. This was definitely, a great session. I've already saved a shortcut to your TED Talk, which I will be checking out as well. So thank you so much. Thank you for taking the time and, of course, giving us your time and your knowledge. It is so appreciated. On our end, you know, the more resources, the merrier. So again, that's great that you're sharing this many. I'd like to take the opportunity to also thank everybody who joined us in the session today. You know, we look forward to seeing you next time. Of course, check out our website for all the upcoming sessions in ECHO, and we have thrown a little link to get your feedback about this session into the chat. So once again, thank you everyone, and have a wonderful afternoon.
Take care.